First of all, greetings from Academy of Pediatrics, Uttar Pradesh, and extend a very warm welcome to our Honorable Chairperson, Professor Mala Kumar, and Professor Sahana Devdas, and the speaker, Dr. Amit Upadhyay, and the senior most faculty members from Uttar Pradesh, Professor R.S. Sethi, sir, Dr. Shirish Patnagar, many other faculty members who have logged in, and all the postgraduates from Uttar Pradesh from outside the UP who have been patronizing the academic activities of AOP UP, particularly the PG teaching program, which is in the second year. And basically, it is the second activity of this year, and we had 21 such activities the last year. So we are now developing this into a very well received and very popular and very beneficial activities for the postgraduates, and also many practitioners are also showing great interest in this. And before I start with the talk, I like to introduce the honorable chairpersons. Thank you, Professor Mala Kumar ma'am, for being giving the consent and sparing a valuable time to be the honorable chairperson of this session. Dr. Mala Kumar is Professor of Pediatrics, NICU in charge, KGMC, Lucknow. She's a Nodal Officer for Human Milk Bank and Nodal Officer, State Resource Center, and past President of Lucknow NNF. She has a lot of publications to her credit and is a well-renowned teacher, academician, and neonatologist from Uttar Pradesh. And it's a good fortune that she has been in our distinguished panel of faculty today, and it will be a great benefit for the postgraduates of UP and all those who have joined in. Our second chairperson, Professor Sahana Devdas, FIPM, SCNU Nodal Officer, Vani Vilas Hospital, Department of Pediatrics, Bangalore Medical College and Research Center, Bangalore. She's also a very renowned and a distinguished neonatologist, national trainer for NRP, basic and advanced, lot of other KMC, FFB, NC, NNSK, member of IAP, NNF, ID chapter, and EB member of state NNF 2018-19, organizing secretary for the National KMC Conference 2021, EBM of state allergy chapter, member board of studies, Sri Siddharth Medical College, Tumkur, Karnataka, principal investigator and prevent trial, member of neonatal state COVID task force, and state mentor for SCN issues. And she has more than 40 national and international publications, and the first Golden Minute Appreciation Award 2021. So thank you very much, ma'am, for being giving your consent and your valuable time and your academic inputs for this very important session. And AOP UP is very thankful for you for this.
Thank you, sir.
So, thank you, honorable chairpersons, and we look forward to a very absorbing session on the very topic, which is seems so simple and but so important and so difficult for the postgraduates. So, and will be simplified, but none other than a very renowned neonatologist from Meerut, Dr. Amit Upadhyay. Everybody knows him very well, but still I'll share his introduction, which I'll request honorable chairpersons to please take over the session from here.
Thank you so much. So it's a very good afternoon to everyone, and it's really heartening to see that we have around 125 participants who are very eagerly waiting for our eminent speaker, Dr. Amit Upadhyay. So Dr. Upadhyay is an MD and a DNB, and he did his DM in neonatology from All India Institute of Medical Sciences. He's got a fellowship in neonatology from Australia, and he was formerly the head of the Department of Pediatrics in Meerut Medical College, LLRM Medical College. And currently he is the director of Newtima Hospital, Meerut, and he is in charge of the ICU there. It's a level 3B NICU. He's got a number of publications, as you can read from the slide, and he works in collaboration with the Central NNF and the Government of India for improvement of SNCUs and neonatal survival. And he's got several workshops to improve quality of neonatal care to his credit, including CPAP, asepsis, nutrition, ventilation, and all in all, he's a great neonatologist, one of the best in Uttar Pradesh. So here we have Dr. Amit Upadhyay, who's also very fond of teaching. So here we are, Dr. Amit Upadhyay.
Thank you, ma'am. Thank you very much for the kind intro. Thanks, Dr. Shalabh, sir. It's really very nice to have so many seniors over there, which is actually the reason why I myself became nervous. It's almost like I am being examined and I'm not
not at all. 150 participants now.
Oh, yes, ma'am. So, Shalabh, sir, shuru kare, sir?
Yes, Dr. Amit, thank you very much for agreeing to for this, giving you your time and expertise. Please go ahead. All the participants to please post your questions in the chat box. Thank you.
So, good afternoon, everybody. And on this neonatal topic of neonatal examination, I would first begin with that few things which should be available whenever we go for neonatal examination is thermometer should be there, weighing scale. We always go with a stethoscope, and a warm room is a prerequisite, as we may have to unclothe the baby, make him naked. So it should not be a cold room. Fresh, clean sheet should be there to place the baby on so that the baby doesn't acquire infection. And preferably mother and the baby should be there. The mother and baby dyad has to be examined together rather than mother se bachche ko le le turant. Or all pediatricians understand the importance of mother being by the side of the baby, because normally हम otherwise तो बड़े बच्चों को या adults को अलग से ले आते हैं examine करने के लिए, but यहाँ mother हमेशा side में रहनी चाहिए.
Sir, please make your slide full screen.
Pardon?
Sir, full screen कर दीजिए slides को. Full screen.
मेरी तो
slide
full screen आ रही है.
Slide show.
नहीं अमित slide show कर दीजिए, नीचे से icon है ना slide show.
मेरा तो slide show ही दिखा रहा है. मेरा slide screen पे ही है, full screen है.
नहीं नीचे वो slide जो दिख रही है अमित, उस पे टैप कर दो, क्लिक कर दो.
मामा
सबसे नीचे देखिए जहाँ पे click to add.
So in this we were looking at what things we should be available with us. Measuring tape should always be there. A watch should be there because we have to with the seconds a needle watch with seconds needle should be there, or stopwatch. In phones most of the time you have stopwatch in your smartphone. Room should be adequately lit because color of the baby is very important to be seen. So preferably examine the baby in natural light. Because you have to assess whether the baby is blue, whether the baby is yellow, whether the baby is pale, and it will, if you have a yellowish bulb light, it will be difficult to examine. And the room should be warm. Keep the baby warm. Don't unclothe him for the entire examination. Whatever area you want to examine, have only that area uncovered. Especially in if a weather is like you have today these days. And then for examination, there are certain things which you need to taking a history is a prerequisite, and doing the examination with all asepsis is very important. So asepsis and hand hygiene is a must before proceeding with neonatal examination. All those who have done some training in neonatology would understand how important it was. And at times when you go for DM clinical examination, after clearing the theory, they would return you back if you don't examine the hand and go on to examine the baby. So if you forget to wash your hands before examining, they would not take an interview at all. Just send you back. You don't know the basics of examination. Before going on to newborn examination, check mother's record, because knowing the history is very important. And in case of, if you are in the delivery room, refer all questions to the mother directly. It is extremely important to ask the mother if she has any concerns about the baby's health or behavior before you examine, because mother is the best nurse, mother is the best examiner of the baby, and her sixth sense is enormous. The slide is not moving after I made this change from my end. Yes, now it is. So when you begin examination, begin with observation of the surroundings as well. What is the ambient temperature and humidity and other paraphernalia? When you start describing the baby to your, say, if you are in an MD exam or a clinical case scenario, then you have to describe how the baby is in the surroundings. For example, baby is being nursed under incubator or radiant warmer with heater output, and you have to tell how much is the heater output in servo or manual mode, continuously monitored through multi-para monitor. So all the small things have to be told. He's being ventilated on, say, conventional or a HFO or a CPAP, and other organ support, like suppose he's on inotropic support, baby has a OG or a NG tube in C2. If he has central line, you have to tell that UVC, UAC is in place. Intravenous access is there in the dorsum of the hand. And baby has, cap and socks which are applied on. So this entire paraphernalia should be described. If the baby is under radiant warmer, then on servo mode or manual mode, he is there. Then you go for your general observation or impression. Most striking details of the neonate, like telling that he is a sick baby, or is a comfortably placed baby, or he is comatose and dull baby. So this is, you tell your general impression you give upfront, so that the ears of the examiner also they get okay, it's a sick baby. So he will also examine or listen to you with regards to that. First and foremost, when we go on to actual examination of the baby, is that of the vitals. Now, one more thing I would like to tell. I would like to talk through this presentation instead of just having the slides and go on. That aim of examination and the time of examination and the scene of examination are very important. My examination will vary as to what I want to examine based on where I am. My history taking will also vary as when at what point of life I am examining this baby. So if I am examining, say, right at birth, my questions would be different as compared to I am examining after about 24 hours or 48 hours. So at first, I have to examine for malformations. Soon after birth, I have to examine for smooth transition. So color of the baby and perfusion and cyanosis may be very important, and cry of the baby may be very important. So if I'm examining at discharge, things in my mind would be different. If the baby has come for first follow-up, my priorities could be different. So know the scenario and act accordingly. So common scenarios are, say, right at birth, on your first visit, or in the NICU. A sick baby examination is different. At discharge examination, and on follow-up, first follow-up, or baby well baby visit or vaccination visit examination. So just know the scenario in which you are examining this baby. And going on to the vitals, when you assess a baby, you have to ask the mother. She would tell, she is part of the assessment. You look at the baby and see the color and the overall general impression about the baby. Then you listen to the baby and you feel the baby. So ask, look, listen, and feel should be important things in overall examination of this baby. In the vital signs, respiratory rate is most important. If you have one single most important thing to look for as a problem in this baby, then it is if you can diagnose baby is tachypneic or not. So if you observe respiratory rate, you should do it for full 1 minute. So you can never be in a hurry when you are examining a respiratory rate. Do it for full 1 minute. It should be about 40 to 60 breaths per minute. And because until unless you do it for full 1 minute, you can't account for periodic breathing. At times, baby has pattern of fast breathing followed by a shallow respiration period in periodic breathing, which is quite common in healthy babies. If we examine only for say 6 seconds and multiply as we do it for heart rate, then your respiratory rate can come fast. If you have a respiratory rate of more than 60 per minute, it is definitely abnormal baby. And what is the next step? Is to recount the respiratory rate. If your rate is above 60, then that means this baby needs a detailed examination, and you recount and confirm for 1 more minute that baby's breathing rate is fast. Look for signs of distress, which will come later on. Look at the heart rate. Now, heart rate, you don't have to count for full 1 minute. You can count it for 6 seconds and multiply by 10, because heart rate usually is regular, unlike respiration, which is irregular in newborns. All peripheral pulses should be felt, and both femorals should always be palpated, and they both should be palpable. Now, in the respiration, again, you have to, if the baby has distress or if there is tachypnea, you look for respiratory distress and try to score the distress. So, Silverman score and Downey score, we won't be going into detail because too many parameters are there. So, Downey score you should always look at. And Downey score is very simple: respiratory rate, cyanosis, air entry, grunting, and presence of retraction. And if the base score is more than 6, there is impending respiratory failure. Normal is 0, obviously. Score of 0 at all, respiratory rate is less than 60. There is no cyanosis. Air entry on both chest on auscultation is normal. There is no grunt and there is no retraction. So this is absolutely normal. It means baby has no respiratory distress, and a lot of problems like cardiac and respiratory can be ruled out. Most of the neurological examination finding of abnormality can be ruled out soon after birth. Now, if you have a respiratory rate more than 80, if the baby is cyanosed even on oxygen, then these are points given to, and this baby is a sick baby. Silverman score is important for babies who have, say, RDS, respiratory distress syndrome, HMD, and please read into this. This is very important. All postgraduate students are asked this question. There are short notes on respiratory distress scoring, and you should be knowing all this. Acorn is also somewhat combination of Downey score. It adds on prematurity as one of the markers in this as well, but otherwise it is almost same as Downey score. Then in newborns, we are all aware that temperature is a very cardinal sign which we have to look for. And one is simple tactile method. Baby is cold to touch, or is he hot to touch, or other peripheries and a trunk of similar temperature. So your dorsum of the hand can be utilized, and you can just touch the dorsum of the foot and the palm and the trunk of the baby. And if it is same and warm, then he is normal baby. If the peripheries are cold and the trunk is warm, he has cold stress and or mild hypothermia. And if the temperature is less than 36, then he has moderate hypothermia, which is important. So this is a baby who has problems, and we should address this issue very quickly. Thermometer is most important. Auxiliary thermometer is what we do for examination, most of the time bedside. But if the baby is in an ICU, then he would be having a probe in the abdomen, which is always placed, the thermistor probe, and that tells the temperature. How is the probe applied is very important, and it should be fixed by tape in the subcostal area just above the liver. That is the best site. You can see how to place the probe. I have put multiple pictures because this is really very, very important. How do we place this probe over here? After this temperature, we need to measure blood pressure. Do all babies require blood pressure measurement? No. All babies don't require blood pressure measurement. But if you have any doubt that this baby could be having a cardiac problem based on if a murmur is present, if perfusion is poor, if the baby is tachypneic, then all such babies should have blood pressure measurement on them. All babies in NICU who require oxygen or respiratory support, all babies who are on inotropes should definitely have their blood pressure examined. Non-invasive oscillometric method is the usual method to examine blood pressure in a newborn. But if a baby is really very sick on ventilator, then invasive intra-arterial blood pressure is the most accurate. This is what the normograms are made from. Whenever you have to measure blood pressure, right upper arm is the place where you have to measure the blood pressure. Ideally, it should be done over a place where there is a single bone. So that the artery doesn't, it's not compressed well between the two bones, because the cuff of an NIBP can be placed anywhere. So if in the lower limb, you have to place above the thigh where femur is the only bone. And in the upper limb, you have to place it over the right upper limb. If you have intravenous line or a pulse oximeter which is placed over there, and then that limb should not be used for measuring the blood pressure cuff proximal to that. Choose the appropriate size cuff. This is very important. The cuff bladder width should be approximately 50% of infant's mid-arm circumference. So measuring the mid-arm circumference is critical. And this should cover about 50% of the MAC. And the length or the width of the cuff should be about the mid-arm circumference. You can see the figure. This very well explains that the bladder cuff should cover the entire arm circumference. That is important. Otherwise, if a smaller than size cuff is used, falsely high blood pressure can be there. If a larger cuff is used, then low blood pressure would be measured. So appropriate size cuff should be used. Normally, the cuff also mentions the mid-arm circumference for which it is used. The 0, 1, 2, 3, 4 sizes are there. And if you can't do that, then you just go by the guideline written on the pulse oximeter, this non-invasive blood pressure. But please do measure blood pressure on all babies who are admitted in NICU. Postnatal ward, you don't need all babies to have measured their blood pressure, but capillary refill time is a surrogate marker for blood pressure in ward. So this capillary refill time, if it should optimally be under 3 seconds, and you place, if the baby is unclothed, then you place your finger over the sternum, you press it for about 3 to 5 seconds, you remove your finger and count it 1,000, 2,000, 3,000, and the reperfusion, that is the whiteness of pressing, should disappear, and the normal color of the sternum or the forehead, the pinkness should reappear within 3 seconds. This would mean that the stroke volume of the heart is good. So if it is more than 3 seconds, that means your capillary refill time is prolonged and it is a marker of shock, unless the baby is also hypothermic. So this perfusion, and pulse oximeter is, the fifth vital now it is said. Pulse oximetry should be used. It's a marker of good perfusion. It's a marker of how much saturation is, how much hemoglobin is saturated with the oxygen. And if you have Massimo, it is even better. Pulse oximeter is a screening test for CCHD, and we'll come on to that also later on. Anthropometry is very important in all newborns. Weight, length, head circumference, and frontal index are there. Weight is measured by digital or electronic weighing machine, and the length is measured using a infantometer, just not by measuring tape placed under the head of the baby. And the baby should be, for measuring the length, he should be supine, and the popliteal fossa should be flattened. The leg should be absolutely straight, and the head of the neck of the baby should be straight, and whole length from top of the head till about where the dorsum of the foot, entire length is to be measured. Occipital-frontal circumference or the head circumference should be measured using a non-stretchable plastic measuring tape. It should not be done immediately after birth because some swelling and edema could be there, and larger than what normal head circumference could be recorded. And occiput, the most prominent point on the back and supraorbital ridge, just above supraorbital ridge, you have to measure the head circumference. Best is to record it at least 2 to 3 times. Normal head circumference is 33 to 34 centimeter, 33 to 35 centimeters. And microcephaly, macrocephaly, we will discuss sometime else. Pondal index is, PI is important for all PG students and PNB students who could be going for exams. Birth weight into 100 divided by crown heel length ka cube. Crown heel length in centimeter cube. So this is how birth weight in grams. So this is important. Birth weight in grams into 100 divided by the length in centimeters cube. If it is less than 2, and a baby's IUGR, symmetric babies will have symmetric IUGR babies will have more than 2 Pondal index. Then after doing this anthropometry has to be looked at with respect to gestation. So gestation age assessment is of most important thing. Best to estimate gestation is your first trimester ultrasound. If that is not there, then look at physical criteria and neurological criteria. If, however, both things can't be done, then just physical criteria can be used to assess the gestation, especially if the baby is neurologically compromised, say like birth asphyxia baby, and you don't know the gestation. It's outborn baby. Baby has been brought by and you don't have any papers. Then just looking at the physical criteria, you can identify. What are the, these are the different criteria. Out of these, New Ballard score is what most PGs do. This is the best. And but the simplest could be either for the physical thing, then the Perkin is the simplest. You look at 4 parameters. You look at just the skin of the baby. You look at just the nipples. You look at the genitalia, and you can tell the gestation overall. So New Ballard score, physical maturity, you score. For postgraduates, I would say that you should memorize number 2. So the 2 score which is given, you memorize all the parameters in number 2, and then 1 and 0 a little bit down you can memorize in your brain. 3rd and 4th a little bit up you can, and you just have to remember that 40 score total पे 40 gestation होता है, and every 5 नीचे जैसे जैसे स्कोर जाता है gestation नीचे या ऊपर 2 से होता है. तो 40 पे 40 स्कोर पे 40 gestation है. 5 कम होगा 35 पे 38 हो जाएगा gestation. So this is just how I remembered when I was a student कि 40 पे 40 and फिर 5 से कम करते हो और 2 से gestation कम होता जाएगा. And how do we remember this big table? Just memorize 2, because आपको बहुत premature बच्चा एग्जाम में नहीं मिलेगा, ना बहुत healthy term playing baby मिलेगा. Usually और 2 से remember कर लें score 2 में जितने भी parameters हैं, and उसके बाद it's easy to remember above and below. Out of these, if you are not asked to do New Ballard score, या आपको examination में कई बार 5-7 मिनट ही मिल रहे हैं, short case की तरह से मिला है, you don't have to do New Ballard score in all, but you have to tell the gestation. Look at the breast, and if the areola is made and you can feel the areola, it is 32 plus. If you can feel well-formed areola, it is 34 plus. If you have testes which are seen and palpable in the scrotum, he is up 34 plus. If you have lot of plantar creases, then it is 36 plus. So just look at these 2-3 things and you can make out what is the gestation. Skin is also a wonderful measure. If the skin is pale looking a bit, then he is 36 plus. Preterm babies have more reddish or a pinkish skin. If there are parchment-like skin and cracking of skin is there, he's definitely about 30 or 40 weeks of gestation. Neurological, again, remember two. All babies, you don't have to do new Ballard score. Newborn is usually a short case, and just these physical parameters are good enough. Then you classify. This is very important. You classify, look at the weight and the gestation. Based on the weight and gestation, you classify the baby into term, preterm, and postterm. And large for date, appropriate for date, small for date. Because if the baby is small for date, that is less than 10th centile for that gestation, the weight is less than 10th centile, you need to monitor such babies for hypoglycemia. Same, if the weight is more than 90th centile for that gestation, you have to monitor this baby for, again, for hypoglycemia, polycythemia. So these two categories have to be identified, whether it's a large for date baby or small for date baby. If you somehow don't have this chart is allowed to be carried in exam, or you can ask for this chart. You don't have to memorize this chart for each gestation and for each weight. So if the weight is more than 3.6 kg, he would fit for large for date. If the weight is under 2 kg and the baby is term, he would fit for being 37-week gestation. You can see 2 kg is the cutoff usually. So term baby under 2 kg, he is IUGR. You can just simply say that. And you will tell that I will monitor blood sugar and hemoglobin or PCV of this baby if he is healthy, otherwise healthy baby in postnatal ward. Then comes the head to toe examination. This is very important examination. The baby has to be unclothed. You have to have a naked baby in a warm room to examine him appropriately. And head to toe, you just can't miss anything. Any obvious malformation you miss, the family will come tomorrow to you. If you are in private practice, that, okay, doctor, this baby has this, and you didn't tell me that my baby doesn't have a testes. You didn't tell me that baby ko ear ki koi problem hai. You didn't tell me that baby has cleft palate. It's very easy to miss a cleft palate if you don't actually look for it. और एग्जाम में आपने अगर छोड़ दिया तो 6 महीने बाद आपको मौका मिलता है. प्राइवेट प्रैक्टिस में नहीं मिलता. एग्जाम में 6 महीने का मौका माला मैम देंगी कि 6 महीने बाद दोबारा आइए और दोबारा से एग्जामिन करने को मौका मिले. सो स्कल एंड फेस वेरी इंपॉर्टेंट. स्कल में आपको साइज देखना है. ऑब्वियसली छोटा दिख रहा है तो 33 सेंटीमीटर से कम हेड सर्कमफ्रेंस है, इट्स अ स्मॉल हेड. शेप के लिए देखना है स्वेलिंग्स, केफल हेमेटोमा, टैपुट, ये सब सारी चीजें रह सकती हैं. सूचर्स के लिए देखना होगा. फॉन्टेनल, एंटी फॉन्टेनल, पोस्टीरियर फॉन्टेनल ओपन होने चाहिए. वेरी लार्ज पोस्टीरियर फॉन्टेनल व्हिच एडमिट्स योर लिटिल फिंगर. ये हाइपोथायराइडिज्म, कंजेनिटल हाइपोथायराइडिज्म की इट कैन बी अ साइन. यू हैव टू नो दैट. लार्ज एंटी फॉन्टेनल मिल रहा है, इट कुड बी अ बेबी विद कंजेनिटल हाइड्रोकेफलस. तो इसको हमें देखना बहुत जरूरी है. IUGR babies have a very large appearing head and large fontanelles. If cranium को examiner कहा कि अच्छा जी मैंने ये भी देख लिया और बताओ, तो he could be just asking for a cranial bruit. he antifontanal पे stethoscope रखा कि नहीं रखा, वो vein of Ganel malformation इन सब में मिल सकती है. सनसेट साइन की आईज जो है उसकी नीचे की तरफ देख रही है एकदम, तो ये हाइड्रोकेफलस की एक मार्कर होती है. लेट हाइड्रोकेफलस, एडवांस हाइड्रोकेफलस में मिलती है. तो स्कल को हम देखें तो एंटीफॉन्टेनल, यू जस्ट एनी पीडियाट्रिशियन जस्ट कैन नॉट अफोर्ड टू नॉट एग्जामिन अ AF. पीडियाट्रिशियन की आदत होती है, वो बड़े बच्चे को भी देखेगा ना तो सर पे हाथ पहुंचेगा उसके, कहेगा नहीं, इच्छा फिर याद आएगा कि नहीं तो बड़ा बच्चा है इसमें एंटीफॉन्टेनल. बट टिल 2 years of age all babies should have their AF palpated once, because rickets can in bigger babies, rickets can lead to persistence of opening of fontanelle, and in smaller babies early closure of fontanelle is also important, and persistence of opening of fontanelle is equally important. If everything is closed, he could be having craniosynostosis. If posterior fontanelle is large, it could be first sign of congenital hypothyroidism. So you just can't miss examining the skull. Dolichocephaly, long head, and brachycephaly, flat head. It could be the first sign of, say, Down syndrome. If there are not many signs, then brachycephaly could be sign of Down syndrome. और ये Downs में पोस्टीरियर फ्रंटल के जस्ट आगे थर्ड fontanel भी मिल जाता है between your antefrontal and posterior frontal. There could be a third frontal which is quite typical of Down syndrome. Downs अगर है आपने मिस कर दिया तो भाई फिर बहुत गड़बड़ है. You just can't miss a Downs. So we can is this Keffel hematoma and caput succedanum. ये बहुत important है, इनमें differentiate करना बहुत important है. Caput तो usually present होता है at birth. Keffel hematoma usually appears after second day or third day, and caput it doesn't cross the suture line. Keffel hematoma will cross the suture line. तो ये simple सी चीजें. Caput is a very hardish swelling, and you can put your finger inside to compress it, but it will refill immediately. So it's very difficult to first 24-48 hours may be confusing, but any swelling which persists beyond 3 to 5 days is definitely Keffel hematoma. Caput will disappear in 2-3 days. Then from the skull you come down to eyes. आईज में सामने सबकंजंक्टिवल हेमरेज दिखता है. उसको अगर है तो एग्जाम में बताना पड़ेगा कि भाई सबकंजंक्टिवल हेमरेज है. तो एक बच्चे को सामने कई बार जब आप देखना चाहते हो वो आईज क्लोज रखता है, तो यू रॉक द बेबी थोड़ा सा अप एंड डाउन, उसको हम थोड़ा सा मूव करें, इससे वो आईज अपनी खोल लेगा. और फिर हमें उसके साइड में देखना है सबकंजंक्टिवल, तो उसको हम हेड को थोड़ा सा लेटरल मूवमेंट करें, आपको सबकंजंक्टिवल हेमरेज के लिए दिख जाएगा. यू कांट मिस. फॉर एग्जाम्पल जो प्राइवेट में है वो कह सकता है कि अच्छा माइल्ड सी चीज है इसका, तो वो नहीं है. बट ऑल दो स्टूडेंट्स हु आर लिसनिंग, यू कांट मिस a finding. This is a finding for your exam, subconjunctival hemorrhage. It shows that there was some problem or some head compression or some difficult labor could have been there. Now, other than that, you can't miss a white reflex. If it is there, you have to specifically look for this red reflex is normal. If red reflex is not there, if it's a white reflex on throwing light laterally, best is red reflex should be examined through a ophthalmoscope, and that is the ideal way to look at. Then you look for any congenital malformation in the eyes, size of the eyes. You have to look for microphthalmia. Then the genetics people need to know more. If you can identify normal intraocular difference, telecanthus, hypertelorism. You can't miss the epicanthal fold. They can be normally present, but if it is present, it could be a marker towards Down syndrome. Epicanthal fold is it's a commonly present abnormality. Hypertelorism is a wide-spaced eyes. Slant of eyes is important to look at. The mongoloid slant, which is there, the upslant. Upslant is, laterally it is going up. This is the typical Down's slant of eyes. Down slanting will also be there. Red reflex we have already discussed. It should always be looked for. Leukocoria or white reflex is abnormal. It could be a sign of cataract. If it's a preterm baby who is coming for follow-up, then it could be sign of grade 5 ROP as well. So it could be a marker of retinoblastoma. So one has to always look for all babies should have their eye examined by the pediatrician at discharge. Then ears, you look for low set ears, abnormal size and shape ke liye. Sometimes abnormalities could be really visible, and a lot of hairy pinna can be a marker of, say, Beckwith-Wiedemann syndrome. And low placed ears could be a sign of many congenital or genetic disorders. So for looking at low set ears, you have to have baby's head perpendicular to the ground. And if you see, and in this Frankfurt plane, if the ear should be, the helix should be above 1/3 of the ear lobule should be above this line passing, the imaginary line passing through the midline of the eyes. So if entire ear is below this, then it is low placed ear, low set ears. You can see this. You can just you can see the eyes. And if you look at the lateral canthus and draw perpendicular line below this, then you can see the entire ear is, entire lobule of the ear is below. So it's a low set ear. The abnormal shape could be there. Overfolding could be there. Sometimes cartilages are less. Anosmia is there. Microtia is there. So if it is there, then you have to go for hearing testing. Any hearing abnormality, normally we do high risk screening for hearing abnormality, which is OAE or ABR. But world has gone towards universal screening. That is, all babies who are born should have a hearing screening done. But this may not be possible in a country like India still. So at least all high-risk babies, and this ear abnormality on examination is a high-risk baby. And we should have his BERA and ABR examined within 3 to 5 days or before discharge. Then you should always examine the mouth and nose. And in the mouth, cleft lip is quite evident at times, but at times very small cleft in the lip is there. That has to be examined and told to the patients. And most important to emphasize over here is opening the mouth and looking at the palate and maybe palpating it. At times there could be a posterior only cleft palate, and the soft palate could be cleft. These are also important to know because some babies may have feeding problem or feeding difficulty. And flat nose tip, depressed nasal bridge, long philtrum, they are all markers of genetic disorders and should be looked at. Mandible, retrognathia is easy to miss. Even in newborns period, it should be diagnosed if it is there, because these babies will have difficulty in feeding. Intraoral examination, we have already emphasized. Look for palate, look for this cleft, which is really gaping. Unless you examine the open mouth, it will not be visible, however. Then these cleft lip, then these Epstein pearls in mouth, and what the mothers are fond of showing, this is often you would miss, but mother will not, and the grandmother definitely will not let you miss this. Iji tatua hai cheko, ye jisse uska matlab hai, this frenulum of tongue is there, and iji abhi katwana hai ya chuna hai. So until forking of tongue is there because of this frenulum, it doesn't need any addressal immediately, and it can be left for later. And most of the frenulum, they don't cause difficulty in talking or speaking most of the time, unless forking is there. So it can be left alone. Natal teeth, they generate a lot of interest and anxiety in the family, and it can cause difficulty in breastfeeding, and it can cause trauma to the breast and nipple and areola. So at that time, or if it is, shaky, not appropriately, then it requires removal. Neck and chest. In the neck, there are many things, but obviously some opening in there should not be missed. Webbing of the neck, short neck should not be missed. And neck length and height ratios are there. Distance between external, we would leave that. But if there is a doubt, family feels that the neck choti lag rahi hai, so then you can make these calculations. Chest mein, location of nipple is important. Symmetry को देखना है, shape देखनी है, और accessory nipples के लिए देखना है. They are very commonly present. Nipple line के अंदर ये present होते हैं, और उसके लिए हमेशा देखना चाहिए. Nipple can be red at times swollen at times, and but not tender. And इसको बहुत लोगों में tendency होती है, if it is swollen, कि इसको squeeze करके इसका milk निकालने, which is milk, which is called. But this temptation should be, given way with, and they should be left alone. Their withdrawal hormones are the reason why they are swollen and enlarged, and they should be left alone. Limbs, one should always look for very carefully, and proportions of limb upper segment, that is from head till pubic symphysis and pubic symphysis rest. So you you measure the entire length, and then you measure the length of the lower limbs, that is from pubic symphysis to heel. and you subtract this lower segment from the total length to get the upper segment. And 1.7:1 is the normal ratio which is there. The arm should be reaching below the waist. The span of the arm should be roughly same as the length of the baby. And abnormality or short limbs are quite common. Not quite common, but not quite uncommon also, it can be said. Especially in the era of antenatal ultrasound, many parents come with the ultrasound and बताया था कि arms इनके छोटे हैं. So rhizomelia कहते हैं इसको, और उसके लिए हमेशा हमें देखना चाहिए. Look at the nails and the creases, fingers and toes. Fingers जो है ये कई बार syndactyly could be there. Polydactyly is very common. जब से thankfully ऋतिक की polydactyly देख के बहुत लोगों में ये इससे anxiety और tension कम रहती है. इसकी cosmetic problem भी कम हो गई है because ऋतिक very proudly shows his polydactyly, and I'm very happy that he has done that. Nails बहुत important है देखने, because you look for the color in nails. That is very important, because if the nails appear blue, and then it could be because of cold hands. Cold stress is also a very abnormal thing. You should address that issue very quickly. But if a warm hand has blue nails, it is definitely abnormal. One should always look for mucous membranes for central cyanosis, and diagnosis cyanosis is, I can't say it is how important it is, but it is very easily missed. TGA at times, is missed because somebody didn't look at cyanosis. Parents को भी नहीं लगता कि उन्हें लगता है कि अच्छा जी थोड़ा सा नीला है, ठीक है, अभी छोटा है, धीमे धीमे ठीक हो जाएगा. Rocker bottom foot. Foot abnormalities are there at times because of abnormally placed baby in the uterus. So breech presentation में आपको foot abnormalities मिल सकती हैं. Very squished in baby, cornuate uterus के अंदर big baby था, twins थे, उनमें बहुत सारे winged foot abnormalities और इस तरह से मिल सकती हैं. One should always look at that. Then हाथों में ये भी देखना होता है कि clinodactyly, which could be a sign of Downs. Absence of middle metacarpal is the reason for that. Often this clinodactyly. And look at webbed fingers. Syndactyly is over here. And short stubby hands, single palmar crease, they should always be looked at. Here are the polydactylies which are there. Single palmar crease is here. This is a typical Downs syndrome hand which is seen. Then joints should be examined whether there is excessive mobility of joints, but it is uncommon. Skin mein hemangiomas are very commonly found, and we just have to assure the parents, unless it is in the high risk area, unless it is in the face, and when they can have an intracranial extension as well. So skin, you have to look in detail. Skin is like a major organ of body. So you have systemic examination, cardiovascular system, respiratory system. वैसे ही skin में dermatological system की तरह से हमें उसको देखना चाहिए. It is so important. Pallor अगर है तो whitish looking skin. Cyanosis for bluish looking skin. Jaundice, so Kramer's exam rule from head to toe. Progression of jaundice is well known. Edema के लिए देखना है, swelling कहीं पे है देखना है, Mongol spots बैक पे रह सकते हैं, पेरेंट्स का कंसर्न रहता है, वो हमें पता होनी चाहिए. Milia which is there on the nose and chin, देखना है. Erythema toxicum, बहुत पेरेंट्स आते हैं कि जी बच्चे के रैश हो रहे हैं, तो ये they typically appear by second, third day on the trunk, and they can have a small white center as well. And so we just have to reassure and say that 7 days, 10 days में ये खत्म हो जाएंगे. Harlequin phenomena, that is half of the baby is red, half is white, ये common है. और it is also autonomic instability के कारण it will go away. Cutis marmorata, which is nothing else than just your good old, it's a complicated name of a simple condition, which is a simple condition. I mottling. Yeah, mottling. So mottled का scientific name is cutis, and cold के अंदर इसमें हो जाता है, unless obviously shock can also cause mottling. So acne neonatorum petechiae should not be missed because it could be sign. It's like skin is like your laparoscopic thing inside. It tells you many inside information about the baby. Scleroderma, you can't miss a scleroderma. Scleroderma agar hai to just severe septicemia mein hai. Blister agar hai so it could be marker of burn, but it could also be कि usko skin dysplasias ho rahe hain. Epidermolysis bullosa, that will be visible just as a blister on your hand. And then you look for nails which are dysplastic or which are absent, and you may know this is EB. So skin should always be looked at in detail. It will give you many systemic illnesses can be diagnosed just by looking at the skin property. The shock diagnosis is primarily by looking at the skin. Asphyxia pallida can be diagnosed by looking at the skin of the baby. Spine should never miss. It is impossible to miss a neural tube defect and a tuft of hair or swelling. Genitalia, पहला सवाल पैदा होते ही इंडियन पेरेंट्स के अंदर रहता है जी क्या हुआ है. तो और कुछ देखें ना देखें, जेनिटेलिया तो आपको वैसे ही देखना है, बिकॉज इस सवाल का आपको जवाब देना होगा कि क्या हुआ है, और लड़का हुआ है लड़की हुई है. तो हम थोड़ा सा और ध्यान दें उसमें कि अगर लड़का हुआ है वी शुड ऑलवेज लुक एट द टेस्टिस, कि एक सिंगल टेस्टिस अगर उसको है तो हमने नहीं बताया, सो इट विल बी वेरी, इट विल बी अ क्रिमिनल, पेरेंट्स वुड बी वेरी एंग्री. We have to tell about any abnormality in genitalia. कई बार हमें मिस कर सकते हैं, जैसे ये बेबी के अंदर है, ये लगेगा कि अच्छा हम पेनिस है, but this could be a hypertrophied because this baby doesn't have a scrotum. So this could be easily a female with fused labia, and this could be a enlarged clitoris. So ambiguous genitalia should be diagnosed. Then anal opening, this is a flat bottom. So anal opening is missing, and these should always be looked at. All the openings should be examined as a part of routine examination for malformation in newborn. Skeletal examination, DDH. Previously we used to call it CDH, canal dislocation of hip. Now it is developmental dysplasia of hip. You have to know the Ortolani and Barlow test for this. Please read it in your book. Ortolani, I remember it as a Barlow is Baharlao. Baharlao means a non-dislocated hip has to be dislocated. So you hold the, lie the baby down prone and supine, and then just hold both the hip joints together. This outer fingers are there on the greater trochanter, and inner this thumb is on the inside of the thigh, and you just try to take the baby, adduct the hip and take it down so as to dislocate the hip which is inside the acetabulum right now. So you dislocate it, try to dislocate it in the Barlow. So Baharlao neck ko from the acetabulum. Ortolani is opposite. You just place it inside. So you pull it out, and the pressure is applied from the fingers to pull it in, and you put this displaced head into the acetabulum. Also, just place the hip on the sole on the on the table and look at the distance. If it is one of the limb is dislocated, then that knee joint would be lower than the normal knee joint. These are the normal some things which are there. We have already discussed. Enlarged breasts are normally present. Melia on the nose is there. Hemangioma, erythema toxicum, natal teeth, Epstein pearls, Mongol spots. So these are very typically present, usually on the back. But PD in their exams, if you miss it, then you may miss the bus. Always look for these. When normal newborn मिला है और उसमें Epstein pearl हमने miss कर दिया, तो फिर हमने क्या उसको बताया? और तो कुछ था ही नहीं. Hypothermia, cold stress हमने miss कर दिया, cold peripheries हमने miss कर दिया, तो हमने क्या बताया? So ये कुछ नहीं. Respiratory system, time is not less. I understand that. In respiratory system, we have discussed respiratory rate is most important. Give full 1 minute to examine rate. If it is more than 60, it is abnormal. Then you look for retractions. Silverman scoring, Downey scoring as discussed, or Econ scoring should be done. And this is most vital sign to be examined. Never miss this. PSBI जो आजकल बहुत emphasize होता है MNCI के अंदर सारे PGs को, उसमें भी first sign is fast breathing, increased respiratory rate. So if rate is high, it is possible serious bacterial infection could be there. Then looking for serious cardiovascular system inspection. Again, looking for tachypnea is the most important sign. In tachypnea due to cardiac disorder, tachypnea will be out of proportion to retractions. Whereas in respiratory disease, tachypnea or retractions would be significant. अगर lungs में X-ray खराब है और तो fast breathing के साथ severity of lung disease बढ़ेगी तो retraction बढ़ेंगी. But cardiac या neuro हम कब सोचेंगे कि breathing rate तो 100 है, but retraction नहीं है. तो ये then you would suspect कि भाई cardiac origin रह सकता है इसमें. And pulse oximetry is part of cardiac examination nowadays, and it's a fifth vital sign. Auscultation हमेशा करना रहता है इसके अंदर कि कोई मर्मर तो नहीं है. Palpation of femorals is a part of this cardiac examination now, and you should just always palpate both the brachials and both the femorals. आपको apex beat देखना है newborns के अंदर. Nobody would expect कि आप apex beat देखें और उसके बारे में बताएं, because but if you have murmur and baby has hepatomegaly, which is a sign of CHF, then you obviously look for try to classify whether it is a large heart on examination or not. Usually murmurs which are present are transient in newborns. And so if the baby is well baby, you don't have to worry much. But if it is a sick baby, then you need pediatric cardiac evaluation and maybe echocardiography and chest. So in cardiac examination, a weak pulse is abnormal. Bounding pulse is not that commonly seen even in PDA in newborn babies. Single heart sound, that is, M1, T1 and A2, P2. So if there is a single heart, then it is a sign of, say, truncus or TOF or hypoplastic left heart. So it is very difficult to make out those single SPP. Our ears are not that compliant as neonatologists to make out differentiate heart sounds. But grade loud murmur is always pathological. Diastolic murmur is difficult to say because heart rates of newborns are high, 160, 180. But never miss hepatomegaly. Liver which is more than 3 centimeters, if you have 4-5 centimeter liver down, then it is definitely a heart failure which is there, and always recognize that. So never miss a tachycardia, tachypnea, cyanosis, murmur, poor brachial or femoral. I have written never miss cyanosis. कोई तो जगह cyanosis कैसे miss हो सकती है? Obvious है. You would realize that is really very easy to miss cyanosis in newborns because हम कई बार छोड़ते हैं अच्छा हाथ ठंडे होते हैं इसलिए नीले होंगे. But always remember cyanosis rule out करनी चाहिए, tongue देख के हमेशा. I would leave this flow chart of pulse oximeter reading कैसे है. Pulse oximeter screening है for congenital cyanotic heart disease. आप lower limb में लगाएं. If saturation is less than 90, then this baby could be having cyanotic congenital heart disease and this baby needs proper evaluation. If saturation is between 90 to 95, then you repeat in 1 to 2 hours. And if again saturation is below 90, then you send for evaluation. But is above 95, then you say that he has less likelihood of having congenital cyanotic heart disease. So lower limb have to be examined. That is important. And mesemo, if it is best to have a mesemo. Murmur in neonate, if it is there in a sick baby, you need an echo. And that's what I would say. If it is in a well baby, a soft murmur, all such babies don't require echo immediately. Just re-examine him after 1 to 2 weeks. Most of the time, such murmurs are PR murmurs and it would have disappeared. Abdomen, important to look at. If there is obvious distension, prominent bowel loops, if it is present, then at times ileal atresia, duodenal atresia, jejunal atresia, or a baby who comes to vomit and you can see an olive at 2 weeks or 3 weeks, then it is there in congenital pyloric stenosis. And look for liver and spleen. If it is palpable, it could be marker of congenital infection. Umbilicus can give you, umbilical infections are very common. And omphalitis, as it is called, just the stump of the umbilicus can be red normally. But if redness goes beyond the stump onto the abdomen, it is always abnormal. And umbilical infections is usually staph related. Staph IV antibiotic would be required. All umbilical infections which are severe, require IV antibiotics. Examine hernial sites, look for bowel sounds, look for anal opening. If it has been said, okay, examine the abdomen, then genitalia and anal opening examination is part of your abdominal examination. Neurological examination, it is very large, a complete topic in itself. I would say just higher mental function, look at consciousness. Is the baby responding to your touch, pain appropriately? Is he responding? Excessive crying could be abnormal. And never ignore excessive cry complaint, because it could be a sign of intracranial hemorrhage, which is not uncommon in small babies. And cranial nerve is difficult to look at, but if there is swallowing difficulty, he could be having 9th, 10th, 11th, 12th nerve palsy. Posture is important thing to look at. Posture and tone. If the baby is lying frog-like posture, term baby, not moving limbs, then he could be having SMA, spinomuscular atrophy, and he could be having muscular disorders. And reflexes, superficial reflexes are neonatal reflexes are the ones which are typically looked at in newborns, and I would say Moro's reflex should be looked at. I would leave this. Habituation, consolability, cuttability, cranial nerve we can leave. It's not required. Motor system is passive tone and active tone one should examine. And symmetry of movements is very important. Symmetry of movement. Now, if you do a Moro's reflex and only one arm goes like this, then this arm which is not moving is abnormal. He could be having a fracture over here. He could be having a Erb's palsy over here. So, a hand which is just lying close to the body, always be wary of this hand, and remove the clothes. See for all symmetry of movements which is there or not. Otherwise, Erb's palsy can be missed, and it is really very embarrassing for a pediatrician to miss Erb's palsy or a fracture of the humerus. Passive tone is just move. हम लोग passive tone हमेशा check करते हैं कि चाहे भाई move कर रहा है कि बहुत लुंज पुंज सा तो बच्चा नहीं लग रहा है, हाथ पैर ऐसे ही जो उठाया ऊपर गिरा नीचे आ गया. So he could be a baby with SMA. Poor tone is there. Hypoxia वाले बच्चों में भी ऐसा मिल सकता है आपको. Poor flappability, हाथ था बस हाथ ला तो बस flappability बहुत ज़्यादा है. So scarf sign upper limb के लिए term बच्चे में the elbow won't go beyond the midline. If it is going beyond midline, he has poor upper limb tone. बर्थ एस्फिक्सिया के अंदर हो सकता है, मस्कुलर डिस्क प्रॉब्लम्स में हो सकता है, हाइपोटोनिया के अंदर रहेगा. स्क्वायर विंडो, heel to ear maneuver is shown over here. कैसे करते हैं? If it is going above till the ears in a term baby, 90 डिग्री से ज्यादा नहीं हो सकता, 90 डिग्री से कम होगा इसके अंदर term baby में. But अगर otherwise it's a sign of hypotonia. Adductor angle, dorsiflexion angle, this we have read. Active grasp reflex, active tone के अंदर रहता है. The grasp reflex, if a newborn baby doesn't have a grasp reflex, it is abnormal. Ventral suspension में हम बच्चे को ऐसे लिटाएंगे, अगर वो बिल्कुल फ्लेक्स जैसे ये फ्लॉपी बेबी है तो उसके अंदर होगा. ये फ्लॉपी बेबी की तरह से नहीं होना चाहिए. एक्यूट फ्लॉपी बेबी जो है, फ्लॉपी इन्फेंट एक शॉर्ट नोट भी आता है, इसके अंदर CNS से लेकर पेरिफेरल तक सारे कॉजेज रहते हैं और वो हमें पढ़ना चाहिए. सेरिबेलर, CNS, एंटी-हॉर्न एबनॉर्मेलिटी, मस्कुलर वीकनेस, न्यूरोलॉजिकल, ये सारे क्लासिफिकेशन इसके अंदर रहता है ना. फ्लॉपी, हाउ अ टिपिकल फ्लॉपी चाइल्ड इज, और ये एक बच्चा आफ्टर 3 वीक्स से कैसे अपना हेड जो है अबव द प्लेन ऑफ बॉडी उठा रहा है. Head lag is equally important. Even a term baby often doesn't have a head lag. So आपने बॉडी इसको ऐसे हमने पकड़ के चेस्ट से ऊपर उठाएंगे. So even a healthy term baby will not have a head which is falling back. So it's a sign of extensor hypertonia or a hypotonic baby. And deep tendon reflexes are also usually not done, but ankle jerk and exaggerated ankle knee jerk should be looked for. Foot reflexes you can leave, stepping reflex, and asymmetric tonic. This is a healthy baby can demonstrate ATNR. Often when you go to examine a baby in radiant forma, he could be just having a relaxed Sunday morning in a ATNR. But we should be able to break it. If we change the head of the baby to midline, it will automatically break. But if it is fixed, then it is a sign that there could be some abnormality. So finally, the take-home message. And the take-home message over here is objective should be to identify a finding which needs immediate intervention versus those which need observation and counseling. Detailed examination requires time. We need to give some time to baby. Busy OPD can there be your eye should be trained so as to not miss any cyanosis, so as to not miss any decreased quality or quantity of movement, and so as to not miss. And one thing which was not there in examination, which you should always do, is have a baby breastfeed if the baby is adequate, or if not, you cannot, don't have the opportunity to examine the baby having breastfeed, then just look at the history of breastfeeding, whether he sucks on well or not. And because sucking is a very complex maneuver, if the baby is not able to suck on the breast, then he could be having some problems as well. And so give time to this newborn examination. And it should be done in an appropriate clinical setting. If a baby who has one abnormality should have a detailed examination for every other abnormality which is there. So if a baby has a malformed ear, however small it is, one should always look for, palate. One should always look for, in that segment, fingers, nails, extra digits, anal opening. If you have a umbilical abnormality or single umbilical artery is there instead of two, this is an abnormality which, if missed at birth, you will never be able to diagnose them. Such babies can be having congenital abnormality of the kidneys or bladder, and you should always get ultrasound. Nowadays, antenatal ultrasounds, they tell you a lot of malformations, and always look for if a guidance is there. Age and gestation of the baby should never be wrongly diagnosed. Parents, पूरा टाइम का है जी, अगर 8 महीने से ऊपर है तो उनके लिए पूरा टाइम हो जाता है, और 8 महीने मतलब 34 weeks हमारे लिए हुआ, which is preterm. So that baby will have feeding problem, that will have hypothermia problem, that will have excessive jaundice problem. So gestation assessment हमारी तरफ से होना चाहिए. और small for date baby है, IUGR है, these babies are prone to polycythemia, these babies are prone to hypoglycemia. They should be identified by your anthropometry. And once you examine a baby, again go back. If the baby is IUGR, then you need to ask कि भाई ये growth इसकी कम नहीं हुई, PIS तो नहीं था, oligohydramnios तो नहीं था. So examine, take history, examine. After examination, ask more history. And thank you. This is what I have to say.
Thank
Hello.
you very much, Dr. Amit. Dr. Sir, you want to say something? Dr. Sahana?
Yeah, thank you so much, sir. Amit sir, for that elaborate and crisp examination of the newborn. It was a rehearsal for us also. And I think a lot of postgraduates are benefited for their exam and day-to-day management of the newborns, I suppose. And there are a lot of questions, ma'am. Would you like to ask, or shall I start asking?
I'll ask.
Okay. You can ask few, I can ask you. Yeah.
Okay.
Yes, ma'am.
Amit, one of the questions is that are there any guidelines for doing a gastric lavage and for testing for anal patency in newborns at the time of birth?
If anal opening is well observable, then you just don't have to put in a feeding rectal catheter to look at anal patency. All babies definitely don't require a gastric lavage at all.
Okay. Then somebody wanted to ask, what is the modified Downey score?
It's better to do the full Downey score and don't look at modifications.
Okay. Then can you tell us something about lanugo? What do we mean by thinning or sparse lanugo?
Lanugo is the body hair with which a baby is born with. And the more preterm the baby, the more these heavy growth of lanugo is there. And it starts disappearing from the shoulder and back. And so thinning of lanugo, as maturity of gestation appears, the lanugo hair starts disappearing. So, yeah.
Dr. would you like to ask Dr. Devdas?
Yeah. How to differentiate, one person has asked, differentiate cephalometoma from subgaleal bleed, sir.
Kiffel hematoma from subgaleal
From subgaleal,
bleed.
yeah.
तो ये बड़ा सिंपल है. Subgaleal bleed जो है वो dependent area में होगा. तो बच्चा लेटा हुआ, it will be usually present in first 24 hours. तो आपको soon after birth मिलेगा, because ये तो birth trauma का process है, वो आपको usually, और उसके ऊपर redness, red hue आपको मिलेगी most of the time. So it will be in the dependent part, it will be boggy, unlike cephalometoma जो कि आपको ऊपर चमकेगा, यहाँ पे forehead के ऊपर आपको दिख रहा है. It will not go back. You can't cross the subgaleal baby. It will cross the suture lines. Whereas cephalometoma will never cross the suture line. It will be hardish swelling, which is, you know, not fluctuant.
Like a hairband also. It's often like a hairband.
Yep.
The swelling.
Until what age?
And also it will be tender.
Subgaleal
bleed is also tender at times. उसको जब press करेंगे, so they would be pain and baby may cry with that.
And
it will be often a sick baby. It will be often a sick baby who has this subgaleal hematoma.
Right.
And sir, how long till what age Ballard score can be done? There's a question.
Postnatal age. Now that is very difficult thing which has never been answered. And I was asked in my DM exam for now, why did not I do a Ballard score in a 6-week baby when he was a preterm? So this depends आपका purpose of examination क्या है. If you are, you know, doing MD exam और तो उसमें I would say 2-3 weeks तक किसी कोई definite utility है. उसके बाद आपको probably only if you are appearing in exam आपको करना होता है. Clinical utility कम है.
7 days is usually taken as standard. Yes. For MD exams at least.
Yes, yes. That's given in OP guy also, sir. Till 7 days. Yeah, and one person has asked whether craniosynostosis starts in utero or after birth. Definitely in utero. Then how to see for cone? Conal atresia.
Coena, unless nobody would normally look for, you know, coenal patency and all if a baby is breathing well. If you have this typical history of that baby, when he cries, he becomes pink and he becomes blue when he is quiet, then this is typical of bilateral coenal atresia. And unilateral will often go undetected unless the baby is admitted in NICU or sister के जब इसको इधर से डालते हैं तो वो feeding tube नहीं जाती है. And otherwise, most unilateral coenal atresia will be missed.
Yeah, one more question. Breast nodule is reliable criteria in IUGR. I think it is.
Yeah.
Yes. And whether dermatoglyphy should be done in all newborns? I don't think so. Anything else, ma'am?
One thing I'd like to say is that we've all benefited a lot by this seminar. And I think postgraduates should realize the importance of a detailed neurological examination of at-risk babies, at least at the time of discharge. Because examining a baby at discharge is like opening for neurological neurological examination is like having a peep into the baby's brain at no cost. You don't have to spend much time. You can do a decent neurological examination in 5-10 minutes, but it has to be done. And the child must be completely exposed, should be on a warmer, should have been fed around 1.5 hours before you examine the baby, and it has to be done. And of the things that one needs to do in a neurological examination, very important ones are to look for the tone, to look for how the baby is sucking, to look for fixation, whether he's able to fixate or not, whether, and what is the moro like. So you don't have to spend hours and hours on doing everything, but I don't think it takes more than 10-15 minutes if the baby is in the proper condition, कि दूध पी कर बैठा हुआ है, 1 घंटा हो गया, सुसु पोटी हो गई, सब हो गया, expose करके उसको देखें. Another thing I would like to say is that these babies those babies in whom we find that there are neurological problems in the examination at the time of discharge, they must be followed up well. Because not all babies who have a neurological deficit at discharge are going to be affected neurologically because the brain is plastic. So with time, some of these things will improve. But definitely, if the baby has a moderate to a severe neurological examination deficit at the time of discharge, the chances are that the baby is going to be affected. And we need to repeat these examinations. There are structured ways of doing this examination. You can follow any one of the methods, and it becomes easy if you write the type of method you are using so that somebody else may be able to also confirm your findings. These are some of the observations that I'd like to make.
Yeah. And examination, I think it depends on whether you are doing it immediately after birth or at least 3 times after the birth you are supposed to do. That is at birth, for ruling out the major congenital malformations and other thing, how the baby has transited from in utero to ex utero. Then within 24 hours and before discharge is very, very important of examination of these babies. And some of the pre-checklists, because we have about 60 deliveries per day. So if you go on doing for 1 hour for all babies, it's humanly impossible. Whether these babies are in the NICU or in the postnatal ward, because we have 300 to 400 postnatal babies around in our hospital. So very difficult. At least quick assessment of these babies you have to do, asking how the baby's feeding is, whether baby has passed urine, stools, and just looking at the outer one, you know. So you can just, without touching also, you can just do that. And when baby comes for an OPD visit, or if the baby is brought for any maternal concern, then it has to be just checked. So that is what I would like to say. And pre-discharge checklist is very important. Many a times, hypernatremic babies, jaundice babies are sent back home and they come with for a readmission. Like, you know, adequacy of breastfeeding, how baby is latching, positioning, how mother is comfortable, and then vital signs and no significant jaundice, and what are the mother's tests and baby's lab tests, and vitamin K and immunization like BCG, OPV, hepatitis B, and then screening protocol, very important, like metabolic screening, like your thyroid, galactosemia, and we have a panel of 5 diseases. I think most of you have got that. DBS, that is heel prick test we do. And then preterm babies, ROP, definitely, and ultrasound cranium. And hearing, as Dr. Amit has said, universal hearing screening is ideal, but in many institutes still not doing. And CCHD screening is very, very important to pick up certain conditions. And then DDH, dislocated hip, you know, DDH screening has to be done. And immunization schedule have to be told to the mom. And then parents, how they are and how the environment is, where they are going, and what are the mother's concerns or parents' concerns, and danger signs have to be explained to the parents. This is from my side, ma'am. Thank you.
And most important reason why we miss an important finding in while examining a baby is that the doctor is not attentive enough. Your mind has to be absolutely open, and you have to be sure in mind what all you have to look for and what should not be missed for. So हमारा अगर दिमाग में है कि मैंने when I realize कि कुछ पेशेंट में मैंने कुछ छोड़ा है, तो most of the time ये रहता है कि वो 4 बार फोन आईसीयू से आया जा रहा है कि अच्छा वो पेशेंट सिक है, आपका दिमाग तो उस पेशेंट में लगा हुआ है, यहाँ जो पेशेंट आपके सामने इधर बैठा हुआ है ना, वो निकल गया आईसीयू की पेशेंट की बात कर, तो उसमें आपने कुछ ना कुछ छुप दिया है. तो आप यू आर इन अ हरी, मे बी इट कुड बी आईएपी मीटिंग जिसको आपको चेयर करना है, उसमें जाना है, और आपने पेशेंट को देखा तो उसमें आप छोड़ सकते हो उसको. Not to be in a hurry while you are examining, and your full attention should be on the baby who is beside you while you are examining.
True.
You may be knowing everything, but आपका ध्यान नहीं है अगर, so your eyes don't see what your mind doesn't want to see. So please.
And even if the mind knows, if you are in a hurry, your eyes won't see anything.
Yes. ठीक है मैम.
Okay, thank you.
Thank you, sir. Thank you so much.
Salam.
Thank you.
Thank you,
Thank you,
Dr. Shana Devdas, the neonatal in charge from
sir.
Bangalore Medical College, and Dr. Mala Kumar, ma'am, neonatal in charge from KGMU. And thank you, Dr. Amit, for a wonderful talk. And before we close, I invite President of the AOP UP, Dr. ALKA AGARWAL, ma'am, to please give our closing remarks.
Thank you, everyone. Good afternoon, everyone. I'm sorry I missed the initial part of Amit's lecture, but I wanted to be a part of it from the very beginning. And I can only say, you know, after the entire discussion and that that it is extremely encouraging to see that, we had an attendance of almost 200, 250 at any point of the talk, and which just speaks for the popularity that this program is having, this activity is having. So last year, what was a newborn baby, has now under leadership of Dr. Shalabh is being groomed and nurtured well. So I'm extremely, extremely happy about the proceedings that have been happening. And my only thing is that, a master trainer like Dr. Amit gave this lecture, and not many people know that besides being a master teacher and trainer, वो बहुत सख्त examiner भी है. तो बस उससे क्लास से करा लिया करो, लेकिन एग्जाम के लिए मत बुलाना उसको. मेरी एडवाइस है सब लोगों को. अच्छा, and my request to Amit also and Dr. Shalabh also, I think we should hold a part 2 of this newborn examination, because without a proper and a detailed neurological examination, this is
yes, ma'am. Actually, the neurological examination, there was no time for it. And I think we can have a session coming out of this session about the neurological examination. Yeah.
Yes. And thank you very much. Thanks to Dr. Amit for sparing his time and being so elaborative. Thanks to both the chairpersons, esteemed chairpersons, Dr. Mala and Dr. Shahana, and all the esteemed audience who stayed back with us to, enjoy the interesting lecture from Dr. Amit. Thank you very much.
Thank you, ma'am.
Thank you all.